psychology, social work, policy and research in New York and the UK. I've been a commissioner in West London since 2016. So yeah.
Great. And Helen, do you want to just say a few words before we kick off?
Yeah, I'm Helen Pocock. I'm currently the Interim Head of Research Operations for South Central Ambulance Service. I'm obviously a paramedic by background, and my research interests are particularly around resuscitation.
Great. So if you haven't been before, the Quality Improvement Network is very much a space for people to come and present ideas, but it is very much meant to be a kind of a place to discuss and work things out. So we do ask people to do a relatively short presentation, a little bit of information sharing, this is what I'm doing, and then we spend the majority of the meeting kind of having more of a discussion and a debate about some of the issues raised. So I'm going to hand over now to Helen and Craig to kind of present, and then we'll take a big chunk of time to have some questions. Just to let you know, we generally do record these sessions and share them on our Knowledge Mobilisation website. If you object to that, please do let us know or turn your camera off or whatever you feel comfortable with. So I'm going to hand over to Craig now. Thank you very much. Take it away.
Okay. Hopefully the slideshow mechanism works. Okay, can you see that?
Yeah.
Okay, good. Okay, well, so thanks, Rowan. So as we mentioned, we've just done the introductions in terms of who we are, but the project that I've been working on with my colleague Helen is a knowledge mobilisation project on basic life support capacity building among the prison population. So as Rowan mentioned, this is the Quality Improvement Network, and we're trying currently to sort of relaunch it. We had our colleague Nick handle the Quality Improvement Network in the past, and he did a wonderful job. And now that the 4KM fellows have taken it on, we want to try to turn it into something that is a little bit more open in terms of people from various contexts can come every month. They can bring research issues, problems around that. We can have like a sort of informed discussion among professionals. So and we may have more to say about that later, but just to sort of set the scene, I'm going to go over, it's a little bit dry for a Friday afternoon, but I'm going to go over a couple of KM slides in terms of what we mean when we talk about knowledge mobilisation. So let me just move the faces here, sorry. So what we're going to cover today is a quick review of knowledge mobilisation. We're going to look at public health, how that impacts the context that we're talking about here in terms of the prison, how the project came about, and then we'll get on to describing the project and the lessons learned so far. So that you'll see when we go along that this project is in sort of like the first third of its progress. So we will be returning later on to sort of update on how it's been going. Okay, so well, it's not. Okay, right, it moved. Right, so there are different terms for knowledge mobilisation that we use. Really, you've got knowledge exchange, knowledge transfer, knowledge translation, brokering, and really the point of it all is knowledge implementation or knowledge into action. That's the purpose of all of this really, is to have research that isn't used, actually brought to life and used within settings. And I'll have to thank Rowan for the next 2 or 3 slides, which I've adapted, but yeah, I can't take credit for this fine work. But in terms of a definition, there's 2 sort of definitions I wanted to go over very quickly. If you look at KM, you can consider it to be the process of connecting research and researcher expertise to individual or organizations in order to make evidence-informed decisions, and that can be about public policy, professional practice, social services, etc. And as you saw, there's lots of different terms that can be considered as. But that definition is very useful, but there's also something that we need to include for the purposes of this project, which is capacity building. And because I think KM and capacity building absolutely go together, because that is one of the ways that research implementation occurs, and it also has a very strong element, which I'll touch on just in a second, in terms of sustainability. So that talks about capacity building, in this case, talks about developing individual and organizational capabilities. It's a dynamic process. It involves some of the things that were described earlier in terms of collecting, appraising, and disseminating research and evidence, but it also has a deep understanding of what the professional context is. Because without a real understanding of what the professional context is and what people are looking for, then it's really difficult to have knowledge mobilization be sustained. It gets back to that idea that sometimes you have researchers come into an environment and do good work, but when they leave, it kind of falls away. Maybe it is kept in a drawer in that sense. So we want things to be sustainable and to be able to continue. And that means that we have to have it co-produced. We have to have it informed and driven by the people who it affects most. Okay, so just to go over these very quickly, 3 types of knowledge mobilization. You've got knowledge transfer or translation. You can think of that as to some extent sort of internal. So that's one person to another. So that's like your corridor conversations. Have you seen this piece of research, etc.? Would this be helpful to you? And then people also coming to you saying, I've got a problem in terms of evidence-based practice and I want to move it forward in this way, and you supporting them in that. So that's like that internal aspect. Then outside of that, we have knowledge exchange, where that's sort of between organizations. You could consider that at its most basic. So you've got higher education institutions and external partners and sort of supporting them, informing them. That comes under things like consultancy, work placements, internships. I mean, we've all seen that for sure. And the third one, which this one is today, is brokering. Excuse me. So that's connecting producers and users of knowledge to facilitate the sharing, understanding, and eventual application of knowledge. So in this case, with the work with Helen, I have begun as sort of the bridge between the evidence that exists, her professional practice, the context in terms of the prison, and that brokering element is to try to bring all of that together so that the research is actually used. And again, as I said, that means implementation is the point of it all, really. So again, as I said, without laboring it, that means what is the context? It needs to be an iterative process. So as you go along, perhaps you have like process evaluations, PDSA cycles, that sort of stuff. And a lot of that is around, I've included this part in terms of stickiness, which comes from the Malcolm Gladwell book, The Tipping Point, which people may have read. And the idea there is that for something to be sticky or long lasting, it has to be relevant and engaging to the target audience. And I think we can come back to the tipping point later on in future QINs to some extent, because I'm getting mildly obsessed with it, but I won't go on too much about that. So public health, this is the bit where, James, you'll enjoy this. So this is the art and science of preventing disease, prolonging life, and promoting health through the organized efforts of society. So I think we all know it's to do with heavily influenced and with a big concentration on prevention, trying to create conditions in which people can be healthy, preventing the spread of disease, preventing injuries. And the idea, again, is when you look at public health, it's supposed to be science-based, evidence-based practice to problems that we see within our communities. What do we do in the local authority? So that's sort of mirrors a little bit some of what was on the previous slide, but practically speaking, we sort of advise the NHS on certain aspects of services. That's a two-way process before we get too excited on it. There's work within the council, obviously, that we do. We work internally with partners in housing, jobs, crime, environment. There's all kinds of public health overlaps there, which keep us very busy. That means that we work together with partners like police, prison, probation, health trusts, etc. Then we also commission or buy services, which is a big part of my job. And we've got big contracts and required services in terms of sexual health, health visiting, behaviour change, lots and lots of work in Hammersmith and Fulham on drugs and alcohol, as there is in every borough. And then there's health promotion. So we're kept quite busy by that. And then when we narrow it down to the context of the prisons, I won't go over this too much, but basically the Director of Public Health is the principal advisor on health matters within the borough in terms of public health. And that includes the prison. The prison is part of the borough and needs to be considered as such and not really forgotten about. So that includes things like joint strategic needs assessments. There's a definite focus on community transition in terms of substance misuse. We want people to be able to have a good, solid handover when they leave the gates so that any treatment they've been having around substance misuse can continue. There's a big risk when people are, when people leave prison, that's when suicide rates spike or when substance misuse programs that are being followed fall away. And so that's got to be, there's a lot of practical work goes on around that. Emergency and outbreak management, I don't even need to go over. We've all experienced that very recently. And then working with social care. Social care has responsibilities to meet the needs of prisoners, but public health needs to be part of that conversation and be involved in making sure that specialist equipment is there. And we have people here today who are experts in that. So thank you for coming, Mary. And this is probably overkill, but it's just a useful slide to be able to look at how the prison sits within the socio-ecological model. So it sort of looks at the interdependency between the various circles in that, sectors in that diagram. So I won't go on too much about that, but the point really there is equivalence of care. So this is this legal requirement that inmates within a prison have the right to the same public health care as the general population. It's a very simple rule, but it's a very easy way to sort of guide the work. And just before I hand over to Helen, this is how I got into putting defibrillators in the prisons. Really, basically, I've been doing a lot of community defibrillator work with my colleague James, who's here on the call today, and we've been putting them in various different housing estates and in publicly accessible areas. But we were approached to say that the prisons was definitely an area where it would be very useful. What we found was that they were available, but they were in the nursing stations. So that's great that they're there, and but it means that there's potentially like a little short delay in terms of if you have a cardiac arrest on one of the 4 residential wings, then the officer could be providing CPR while someone goes and gets the defib, and that's great. But I think the prison itself and the deputy governor approached us and said, well, maybe we could get defibrillators so they're a lot more accessible and visible on the wings. And that goes back to that commissioning rule. Okay, so I think, Helen, did you want to pick up from here and then we can chip in together?
Yeah, why not? So my interest is, as I said, resuscitation research, but also we've got particular focus on reducing avoidable health inequality at the moment. And prison represents one of those populations where there's massive inequality. Yet we know that there is this principle of equivalence, whereby people in prison should have the same opportunities for healthcare as those not in prison. So this is obviously a project I couldn't do on my own, so that's why I've teamed up with Craig and people at Wormwood Scrubs prison. So the project that we're talking about today, this is part of Craig's Knowledge Mobilisation Fellowship, and it's part of the preparation for an application for a fellowship for myself. So we're talking about one aspect of Craig's project and one aspect of my proposed project. So next slide, please. Thank you. And really, I came to prisons from looking around at the evidence, and we know that people that are in prisons are really disadvantaged. They tend to have much poorer health outcomes. We also know that the prison population is ageing, and there's a bigger proportion of over 50s. And you also see frailty starting from a younger age amongst this population. So people who end up in the prison system tend to come from really disadvantaged backgrounds in the first place. So they're already at considerable health disadvantage. And so also that we see that the median age of death in prisons is much lower than outside of prisons, and it's very often from non-natural causes. So the Inside Healthcare report identified a few changes in relation to resuscitation that could potentially move the dial a bit. So recognising deterioration really quickly is so important. Then having a really good, robust, quick BLS response, and then actually getting organised from getting that prisoner to wherever they've collapsed to the hospital really quickly. And that's what I'm going to talk about next, because there's lots of stuff in the reports that give you a kind of national picture and talked about things like big delays to basic life support starting because prison officers maybe didn't feel equipped to or trained to actually perform BLS. But what I wanted to know was what's actually happening in my locality. So we did an audit, myself and Charles, who's also on the call. Next slide, please. And I suppose one of the key things we were interested in was this bystander CPR. And when we say bystander, it kind of suggests that somebody's just standing there watching things and not doing anything. But what we mean is the person who is on scene first, who is there. They may or may not have witnessed it, but they're the person that's there first. So what we observed that the bystander was very often a prison officer, unsurprisingly. I should say, actually, we only identified in a 4-year period 25 cardiac arrests in our region. So it's quite a small data set, but I'll tell you what we found in our particular area, which doesn't actually cover Wormwood Scrubs. We're a different region. So we found that the median time between when that bystander first got to the patient and the arrival of an ambulance was 19 minutes. That's a long time to leave somebody who isn't a professional healthcare provider doing BLS CPR. So obviously it's really important that the people there on scene are really confident to do CPR and competent. There were some delays. Generally, it was because there was a ligature in place and there were very many cases of hanging, sadly. So the ligature needed to be removed before BLS could start. But encouragingly, bystander CPR was provided in all but one case. So next slide, please. Now, ambulance services are measured on their response times. And when we talk about response times, we're talking about the time between when the call is received to when the ambulance actually arrives at the address of the incident. So we found a median 11-minute response to actually get to the prison. But what we don't record so well is how long it actually takes to get to the prisoner who's collapsed. And that's a further 8 minutes. So not only do we need to support those people who are delivering BLS on scene, we need to support our ambulance crews to actually get through the gates of the prison and get through all the other gates to get to the prisoner. So that's another part of the project. But what we're talking about today is really upskilling the prison officers. Next slide, please. Now, you think that if prison officers are trained in basic life support and they've got these defibs available at every prison, that we should have really good outcomes from cardiac arrest, but actually we're not seeing that. And what we did, Craig and I went in to speak to the management, the prison staff and some prisoners in Wormwood Scrubs, just to get a view from all of them about the response to cardiac arrest. And it was really interesting talking to the prison officers, because I suppose I assumed that they got regular update training and regular practice at basic life support, but in fact they don't. They'll get it once during their induction, and then they could potentially have a 20-year career without doing any refresher. Now, perhaps I'm underselling Wormwood Scrubs, because I actually think they do refresher training, perhaps not as regularly as the prison officers that we spoke to would like it, but they do have refresher training. But having spoken to other people, I know that that's not the case. That's not the national standard. So there's definitely scope for doing a really tailored refresher training for this group of people. Thank you. Next slide, please. So the study design here is looking at 3 phases of research. First of all, was really finding out what staff's knowledge, skills and prior training is in basic life support, but also importantly understanding some of those psychological and social factors that drive them to perform or maybe not in an emergency situation. Because the next stage then is to come up with a tailored training package that's co-designed and informed by the theory of planned behaviour. So the theory of planned behaviour talks about knowledge and skill, but it also talks about intention to act, and it also talks about social norms, and those can be such important motivators or demotivators from acting in that emergency situation. So we really need to take all of those things into consideration, and as well as things like preferred learning styles, opportunities for practice, and the general security constraints in the environment of the prison. So then the third phase is actually delivering and evaluating a tailored training package. So we'll be looking for a change in knowledge, a change in competence, but also a change in confidence, which is really key. And then thinking beyond this particular environment, could that package be transferred to other professional groups? Thank you. Next slide, please. So the data collection methods that were used in the study, we'll be doing some document analysis, semi-structured interviews, observations and simulations to really try and understand sort of the baseline and how things are at the moment. But I suppose the most important aspect on this diagram is that co-design workshop, so that it's not researchers going into the prison and telling them this is how it's going to be, but it's a real opportunity for a two-way conversation and two-way sort of production of the training in the way that they would like to be trained. So all the way through, we'll be considering those sort of sensitising concepts of equality, diversity, and accessibility and reciprocity. That's fine.
No, I better say, because I put this in about
okay.
an hour beforehand. So, but this was just to unpack those co-production concepts, really. So if we look at it in terms of equality, obviously everyone has something to contribute. Diversity, you want to get as much of a wide range of voices as possible, including seldom heard groups. We talk about accessibility, making sure everyone can participate fully. And that includes providing support where needed. And reciprocity, I think you already definitely mentioned, Helen, is huge. Some of it we'll talk about in the lessons learned, but it comes into like sort of what's in it for me kind of thing. And that's not necessarily a selfish thing, but you've got to think in terms of what will the prison staff, the prisoners themselves be able to get out of this. Again, it's got to be something, it's got to sit with them in terms of its usefulness. So it's mutually beneficial. But that was just a little bit more detail on that. I could go next slide, please, if you like.
Yeah, thank you. So with this aspect of the package, what we're looking to do is increase knowledge and expertise amongst the prison staff, and also build their confidence and self-esteem, which are important drivers of action in these emergency scenarios. But a lot of the exploration is going to be around what are the barriers and facilitators to the process of co-production, because it's a new research methodology for me. And what we want, the main outcome is to produce an implementable and scalable package for prison staff refresher training. Thank you. So what I haven't really talked about with this presentation is there is another aspect to this that I think is really important, and that's actually training the prisoners themselves. So we were quite aware quite early on that you can't just go into a prison and say, right, we want to come in and train your prisoners. What is the prison going to get out of that? And actually, when we unpicked the emergency response, we became aware that actually the prison officers were as much in need of some training as the prisoners. So I know I haven't talked a lot about prisoners, but I haven't forgotten them.
Yeah. Yeah, other lessons learned so far, when we met with the Deputy Governor and talked to staff and prisoners, you underestimate how busy the prison day is, really, surprisingly, and you've got to fit in with what works for, if beginning with the staff training, what days will and will not work. Again, sort of being pragmatic and realistic about how you fit in the intervention and the research around it. Other parts that we had were advice from other stakeholders is vital. There's lots of things that we hadn't really considered. So that needed to be included in it. Helen, you could probably talk about the ethics application better than I could, but that in itself, including the security clearance, is something that is definitely a consideration.
Yeah, so as researchers, I suppose we're used to, we get approval from the Health Research Authority and it's like, great, we're good to go. But actually, if you're doing research in prisons, the number one lesson is nothing happens without the prison governor being on board. So you've really got to get good buy-in from the prison governor before you even get through the door. but there's two ethics processes to go through for research with prisoners. Obviously, they need additional safeguards to ensure that everything is, we're avoiding coercing people into taking part into research. So there's a single process of application, the IRAS process, but you apply effectively for NHS ethics approval, and then at the same time you're also applying for prison ethics approval. On top of that, the process for actually getting security clearance to do your project can take a lot of time. So I'm really glad to have spoken to lots of different people who were able to give me advice in advance and sort of warn me of some of the pitfalls of trying to do research in this population. One of the things personally I found is that it's been really helpful to, as well as having conversations with lots of people, is to have a buddy. And I feel that's what Craig has been up to this point. He's really kept me going and kept me thinking about things in a different way. You certainly need time out of your normal work to actually focus on building this kind of work up, and have somebody there just to sort of keep you going and keep you on track and motivated has been a real benefit.
I'd say that's a two-way street as well. I think we kept each other going, really. I mean, definitely, for sure. I added in the stuff around context being under pressure, and that's connected to the fact that progress can be slow. I mean, we've seen, honestly, if you see something on the news regarding prisons, I think to myself, oh boy, that's going to slow us down, because all the prisons have to respond to that. They have to review their own processes, understandably, and so there's often internal things happening that makes it difficult for the prison to get back to us as quickly as we might really love them to. But so progress can be slow, but I think based on the purpose of it and what we can get out of it and the long-term potential, I think it's definitely worth sticking with.
Yeah, and that's particularly evident when I was looking through the patient records doing the audit. These are young, quite often otherwise fit men who are taking their own lives in prison, and anything that we can do to try and help save those lives has got to be beneficial. If we can additionally train them and upskill them in basic life support provision, when they go back into their communities, they're taking life skills with them, they're contributing into that community that they're going back into. So for me, that's what makes it worthwhile.
And that's, yeah, we didn't have a question slide, but obviously whether or not there's any questions. Should I stop sharing?
Yeah, thank you very much, Craig and Helen. That's really fascinating. Yeah, any questions from anyone? Feel free to raise your hand or open your mic. While you're thinking about that, I'm fascinated by that. I've been into forensic services, and I know you have to give over your phone and you have to go through a whole process. Does that slow things down in terms of you can't take your phone or other devices in? You're up down to pad and paper when you're in there?
I didn't feel like that really slowed us down. Helen's better at taking notes on paper than I am, but they were really good at helping. They get so many visitors. They were really good at helping us to plan for it, and like give the phone over, etc., that sort of thing. So it's those parts there actually the prison has been very helpful with. But yeah, you've got to think of those things. I mean, we had to ask, can we take in a laptop, etc., in the future, and like what would be the process? And if you get it, there's Mary shaking her head. So yeah, that's the seasoned experience there.
Yeah. Charles, you had your hand up. Go ahead.
Yeah, thank you. Now, I was just going to say well done to both of you for all this work. It only takes 10 minutes to present, but it actually takes quite a lot of time to actually get to the stage of collecting data, not least collecting the data itself. So fantastic, well done, because there's a real temptation with research just to go for the stuff that's easy, but often the stuff that's difficult has got all the important questions and areas we can make an improvement. I mean, this at the moment sort of is nationally sort of slightly under the radar, but it's a huge problem across the UK. And I know we've just focused on 1 or 2 hospitals, but actually if you extrapolate even from our region, those 25 cardiac arrests nationally. I don't know the exact figures offhand, but it's a very disproportionate number of cardiac arrests for the size of the population. And I'm sure there would be a lot of interest nationally in terms of the Home Office and prisons and so on, looking at this data. A lot of the benefits of this are going to be finding the right people to present it to. I'd certainly be, I've got a few links with the Home Office. I'd be certainly happy to try and help with that. But I do quite a lot of medico legal work and often review deaths in custody and deaths in prison, and all these delays are a common theme, and so is the criticism that ensues. So I'm sure that there would be a big appetite from those involved in organising prison healthcare to actually work with you to see what lessons can be learned and try and put things in place to improve these delays, because there's no doubt that there's a lot of morbidity and probably mortality from some of these delays, and it's a clear area of health inequality. So I think this has got a lot of mileage in it, and you know, the real benefits will be getting it out there in the national arena. But well done, both of you. It's great.
Thank you,
I
Charlie.
agree. Laura, I think you were next.
Thanks, guys. Really, really fascinating. And yeah, I've been talking to Craig a little bit about the project, but I'm glad to hear a bit more detail of it. I have two questions. Maybe I'll just start with one, though. I was glad to see in your kind of what we've learned so far and the planning that you've talked a little bit about like the day-to-day and how this is going to fit with what is actually happening in the prisons. And I wondered if you guys could say any more about how training for the prison officers, you know, you said it's not done for this specific topic, but is there a consistent program of training for them at all to upskill in any other areas? And maybe thinking about how this fits within that eventually, so it's not something on top of, and if it's not something that even exists, it'd be really interesting to hear as well.
Yeah,
Go ahead, Helen. Yeah.
They do have I think it's weekly meetings, not for all of them, but small groups of prison officers at a time. There is a weekly session, but I think it's like half an hour to 45 minutes long. So that's where we thought there was scope for just getting this into that meeting. Was that your understanding, Craig?
Yeah. Yeah. So there's training days put in place, and officers are trained in CPR when they first join, but like Helen said, that means that you could have a really experienced officer who hasn't had refresher training in 5-10 years. It's quite possible. And when we actually spoke to staff, they had variations in terms of how confident they felt. Some of them felt like they were okay, and then others like didn't. And that had, in practice, that had shown where certain officers had been able to deliver CPR, but other officers hadn't felt so confident. So there was those gaps. And so a lot of it is around also the consideration that you can't take officers off the, let's call it the front line. If they're scheduled to work that day, there's no way they're going to be able to attend the training. So some of that is about like a careful coordination of how many people could we get, when could we get them, you know, that sort of thing. We don't want it to be burdensome. We don't want to be in the way, and we obviously can't interrupt business as usual. So we're actually at that part of that stage at the moment, really, of trying like scheduling things.
And do you guys have a time frame for how often you'd want a refresher? Because for people who work with like vulnerable populations or in nurseries or in, you know, things like that, there's probably a yearly, I would assume, refresher. But is there a timeline, or is that part of the process of co-production?
I think that will be part of the process of co-production, but it would be great to be able to provide annual refreshers. It wouldn't be us actually delivering. The aim of this project is it becomes sustainable. So we would aim to train the trainers within the prisons so that they can keep this running after the research is finished.
Thanks so much, guys.
Yeah, some really interesting challenges for that particular population. I think, Mary, you were next.
I just wondered whether it might just help for me to give 2 minutes further background to the prison and the complexity.
Absolutely, Mary. Yeah, if you'd like to give a little introduction of yourself, that would be really useful.
Okay. Well, I was half my life I was a old age physician, so I'm a physician, but also public health physician, and I was the public health physician for everybody in prison for a very long time, 20 years. But I have been going into Wormwood Scrubs until very recently, seeing veterans of the armed forces. So I feel I know a little bit about the prison, and also I'm now key trained, which maybe I could just add to that complexity. So at the moment, there's 1,270 people in Wormwood Scrubs. There's quite a rapid turnover, people going to court, people coming back. I would think there could be like 35 new people every day, and other people who've come back from court. We talked about the ambulances, so that's quite difficult. So people will contact the ambulance service, but again, you've got to get through the first gate. Everywhere you've got to get through a gate, and you cannot leave the gate unlocked. So that's part of the time, and also from the gate to the wings can also be quite a bit of time. There was just two things I was thinking about staff, because of course it's not just prison officers. I mean, men go out to work every day, or go to workshops, or go to education. So I was thinking here that you now have defibrillators, I think, in the workshops. There wasn't one in the kitchen, and there wasn't one in the gym, which I think they're there now. Are they, Craig?
Yeah, I believe so, yeah.
Yes. So there are other staff who would be important. And the other thing is, yes, Helen, you talked about self-inflicted deaths, but my beef is ischemic heart disease, so cardiovascular disease in prison. And it is for the natural deaths, and it's odd context to say, but we say natural meaning anything physical, and the others self-inflicted, or the non-naturals are also interesting because they're often associated with illicit drugs, but they of course may also have ischemic heart disease. So those would be the important things. And also prison ethics can take its time, so if you're wanting to do it, start right at the beginning. Yeah, and well done for Helen and Craig getting so far.
Thanks, Mary.
Thank you.
Yes, well done. Any other questions?
I'll come back in if I can.
Sure.
I just wanted to have a brief discussion, because we usually talk a lot more about, the normal kind of quality improvement healthcare settings in hospitals and maybe community to some extent. But this being such a different environment, I'm really curious about almost like the culture for improvement being so vastly different for you guys, and entering into a space where we're usually thinking there's a pull for improvement, like people are really maybe motivated and have a bit more space and time. They're advancing their careers by being involved in quality improvement, etc. And I'm just wondering if that kind of culture at all exists, do you think? Or are we really also trying to build that, hospitals try to become improvement centers of the universe? Is there a space where prisons might want to also be seen with that, lens of, we're really trying to make things better for our population? And whether or not, I think by doing a project like this, you're probably building it, but it's just really, I think it's an interesting maybe avenue to have to tackle as a group going in to do this work as well.
That's a really interesting question. So I have the impression that perhaps some prisons have their experience of research has been researchers have come in, done their research to them, and gone again. So we're really keen to avoid that. So that's why we're spending so much time trying to develop relationships. I can only tell you what I heard when I went around asking questions, and I have to admit that the Deputy Chief Governor was right behind me when I was having those conversations. But There did seem to be a lot of enthusiasm from the staff to get involved with this kind of project. But like I say, that was with the Chief Governor behind me. I wonder whether Mary might have a better feel for that.
Oh, you're on mute, Mary, I think.
So I'm back now. Helen, was that, sorry, can you just repeat the question? The numbers, were you saying?
No, it's more about whether there's a culture of wanting to improve.
Quality improvement culture.
Yeah.
Most certainly, especially at the governor level. I mean, the two governors in Wormwood Scrubs are quite remarkable. So they are very, very receptive indeed, and would like anything that makes life better for them. I mean, that might not be common around the place, but also in South London, I'm going to join a meeting next week, and so I think they're too forming a prisons network. And I know that at Oxley's Trust, so my colleague is so he's a forensic psychiatrist, but he is the director of research, and they've got 13 prisons in their patch, and they are very enthusiastic. I think it's just understanding the time, because you think that you've got all day, but actually people are locked up over lunchtime, and as I say, it's quite a busy activity. And the other thing really is, it's one thing, isn't it, training in basic life support, but also I've never seen the team. So the team to be doing it together. I mean, the numbers are quite small at night. It's tricksy, but people. Yes, I think one should always be optimistic in this environment, and if you start like that, I'm sure that you win through in the end.
Yeah, I think the thing I would add to it is you can tell from the way the prison is set up, and this is me as I was a bit of a novice before the beginning of this. The processes that they've put in place, like they have a reception wing for when people are spending their first night in prison, and you have people there who are kind of mentors to mentor prisoners, so they have like a successful, safe entry into the prison. They think of a lot of different things. The medical team is really on board in terms of trying to support this work, and even the prisoners themselves, when we spoke to them, they were very open about the idea. They would be very happy to have a go, or like to support someone if we were trying to do training, and the peer-to-peer learning was all there. So if you sort of separate the quality improvement into various other elements, you can definitely see that there's a lot of it there. There's a lot of potential there, I think.
Any other questions from people? While you're thinking, again, I'm more experienced in healthcare and hospitals and community rather than prisons, but it always strikes me as it seems very contained and very hierarchical, the prison environment. Does that leave any room for kind of empowerment and people motivated and engaged and wanting to change? Or is there a kind of, they want to change, but the boss above them says no? I mean, is there quite a lot of hierarchical power there?
I'll just start with my answer on this. I feel there's so many people in there that, I mean, the hierarchy can't really necessarily overcome the relationships that people have and the connections, and so yeah, it's more structured, I think, than hierarchical. But there obviously is a hierarchy there, but that structure's there for a reason, obviously. But I mean, just on the initial scoping stuff, we found that there was plenty of opportunity for lots of productive interactions. Yeah. You felt that, Helen?
Yeah, I felt that there was a hierarchy, but at the top of that hierarchy is enthusiasm. And
Yeah.
if you've got that from the top, then that does often pervade right down. So I came away really, really inspired and optimistic from visiting that an environment that I thought wouldn't be welcoming at all, and it was quite the opposite.
Do you think there are any lessons learned? Because obviously for the last 10 years, there's been quite a lot of improvement going on in various different trusts in healthcare. And some of them have had their challenges of engagement and ethics and security clearance, and especially if you're working with vulnerable adults. And, you know, are there any lessons learned that you can draw across from there, do you think?
Mary is the expert on that.
Oh,
Yeah.
okay. Mary, go ahead.
Lessons. Well, one thing I'd say about hierarchy, the prison service, I think, is an example where hierarchy works. It is a command and control organisation, and so say like a typical example. I mean, I know it's odd, but you know, restraint has to occur, but it goes right from the top. It is a completely standard method, and so, you know, if you get a good outcome in one place, you know, one could be optimistic that you can repeat it. The thing about healthcare, well, there ain't enough. I mean, you know, we talk about equivalence, but actually the need is greater. You know, they say, oh, well, we should strive towards equivalence. Well, I'm really sorry, we're nowhere near that. You know, if you said how many staff there are, you've got, as I say, back to the 1,200 men, you know, how many people can you see in a general practice, that sort of thing. So the pressure on the health side, you know, I mean, I'm just an advocate for saying it's not enough and it needs much more investment. You know, you just have to keep on trying, but that's what's needed as well. But you know, no, you know, I've always found people are optimistic, very much so.
Okay, great. We've got about 10 minutes left, so any last questions while people are thinking of it? Can I ask Helen and Craig, what's your next steps? You know, what's the future like for this project?
So currently we're discussing with the prison, like the actual nuts and bolts, the practicalities of getting in to do the training, and that at that point will include restarting some of the scoping work with staff as we go along. So that's we're experienced a bit of a slowdown for a while, but we're now at the point of like, can we get back in? And some of that is involved from my side, conversations around other needs in the prison, which Mary has been very supportive and helpful on, where we're talking about what are the social care needs, who needs to be in the conversation, specialist equipment, all sorts of things, all sorts of public health and social care needs that the prison has, which goes back to that, what's in it for them, because we can help them improve their processes there, and we can also come in and do the training and the evaluation and the research, so it's all sort of interrelated.
Next steps for me is an application for an NIHR Fellowship.
Oh yeah, that's right.
Yeah.
We haven't mentioned that yet. Yeah.
Good luck. Yeah.
Thank you.
I mean, let me know if you need any help with that. I've done quite a lot of NIHR applications, unfortunately, and sit in some panels, so happy to help with that.
I shall be knocking on your door then.
Any last questions before we finish?
Yeah, so it's not a question, but it's just going back to the thing which we want to send out that plea in terms of we want to use the QIN as an opportunity for people. We want people to come back. So people who are here today, like, we're not always going to be talking about prisons, but we want to be able to discuss knowledge mobilization and research and things that people may be stuck on, context that they need to be able to move forward. We want to try and build the network in terms of expertise and skills and be able to have conversations. So it's just sort of that comment, really. So,
do you think of it as a community of practice?
Yes, that's it, Rowan. That's good. Yeah.
Where we come together and can kind of, I guess it's a bit of a safe space to explore. This is what I'm doing. This is my challenge, and what can I do, and draw on the network for any ideas.
Exactly.
So,
Yeah.
Any
so you're all welcome back. For example, Samantha, James, Stephanie, Andy. Yeah.
I would just add to that as well, you know, if people want to come and present or know someone within their network that wants to come and present, then please let us know. You can just send us an email and we can sort out the timeline and when's best for you to do that. So yeah.
Do you want to
Always
put the
looking
email
for-
in the chat, Sophie?
I
Is it
can
the
do.
knowledge mobilisation email at
Yeah.
udbwell.ac.uk?
I will do that now.
Brilliant. And just to let you know, as you might have seen from the invite that went out to you, there is also a microsite, a kind of little website where we gather together who's speaking. And we also will post the recording on there as well, so that you can access the recording if you want to check back or see anything that happened, or contact the speakers if you've got anything that comes up for you in the future as well. You can always check back in with them. Okay. Any last comments before we end? It's always good to end just a few minutes early so that you get a little bit of time to actually breathe before the next meeting. Great, I'll finish us there. Thank you very much for joining, and thank you very much, Craig and Helen, for presenting. Really interesting. Thank you very much.
Thanks very much.
Thank you, everyone.
Thank you all.
Thank
Take
you.
care.
Thanks for
Bye.
joining.
Bye.
Bye.
We're going to do a debrief.
Stop the
So